Venous thrombus. Phlebitis is an inflammation in the wall of a vein. The term is used clinically to indicate a superficial and a localized condition that can be treated with application of heat. Superficial thrombophlebitis is a condition in which a clot forms in a vein secondary to phlebitis or because of partial obstruction of the vein, more commonly seen in the greater or lesser saphenous veins of the lower extremities. Phlebothrombosis is the formation of a thrombus or thrombi in a vein. In general, the clotting is related to stasis, abnormality of the walls of the vein, and abnormality of the clotting mechanism. Deep veins of the lower extremities are most commonly involved. Deep vein thrombosis (DVT) is thrombosis of deep rather than superficial veins. Two serious complications are pulmonary embolism and post-phlebitic syndrome. While the terms do not necessarily represent identical pathologies for clinical purposes, they are used interchangeably when discussing the same process. Pathophysiology and etiology. Three antecedent factors are believed to play a significant role in the development of venous thrombosis. First one, stasis of blood. Second one, injury to the vessel wall. Third one, altered blood coagulation. Virchow's trade. It is called Virchow's trade. Pirchhows. Virchow's trade. Tread. Virchow's trade. Usually, 2 of 3 factors occur before thrombosis develops. Thrombosis related situations: venous stasis following operations, childbirth, or bed rest for any prolonged illness. Prolonged sitting as a complication of varicose veins. Third one, injury, bruise to the vein may result from direct trauma or internal trauma as from IV catheters, infusion of medications and or infiltration of medications. Fourth one, extension of the infection of tissue surrounding the vessel. Fifth one, continuous pressure of the tumor, aneurysm or excessive weight gain in pregnancy. Sixth, unusual activity in a person who has been sedentary. Seventh one, hypercoagulability associated with malignant disease, blood dyskaryosis. High risk factors: malignancy, previous venous insufficiency, conditions causing prolonged bed rest, MI, congestive heart failure, sepsis, traction, end-stage cancer, HIV or AIDS. Leg trauma, fractures, cast, joint replacements. General surgery over 40 years of age. And obesity, smoking. Clinical manifestation. Clinical features vary with site and length of affected vein. DVT may occur asymptomatically or may produce severe pain, fever, chills, malaise and swelling and cyanosis of the affected arm or leg. Superficial thrombophlebitis produces visible and palpable signs such as heat, pain, swelling, erythema, tenderness and induration along the length of the affected vein. Extensive vein involvement may cause lymphadenitis. Diagnostic evaluation: venous duplex or color Doppler. Ultrasound is commonly used. This non-invasive test allows the visualization of the thrombus, including any free-floating or unstable thrombi that may cause emboli. Most effective in the detection of thrombus in the lower extremities. Second one, impedance plethysmography, IPG, a non-invasive measurement of changes in cuff volume corresponding to changes in blood volume brought about by temporary venous occlusion with a high pneumatic cuff. Electrodes measure electrical impedance as cuff is deflated. Slow decrease as impedance indicates diminished blood flow associated with thrombus. RF testing. Radioactive fibrinogen is administered intravenously Images are taken through nuclear scanning at 12 to 24 hours. The radioactive fibrinogen will be concentrated at the area of clot formation. Venography, intravenous injection of the radiocontrast agent. The vascular tree is visualized and observation is identified. Coagulation profiles, PT, PTT, INR, circulating fibrin, monomer complexes, fibrinopeptide A, serum fibrin, and protein C and S, antithrombin 3, third levels. Detect intravascular coagulation. Management, the goal is to prevent propagation of the thrombus, prevent recurrent thrombus formation, prevent pulmonary emboli, and limit venous valvular damage. First one, anticoagulation therapy. Heparin is given IV initially, followed by 3 to 6 months of oral anticoagulant therapy. Second one, heparin and enoxaparin may be also given as subcutaneously as prophylaxis for the prevention of DVT, especially in postoperative and or immobile patients. Thrombolytic therapy may be used in life or limb-threatening situations. Most effective in dissolving existing clots within first 24 hours of thrombolytic event. Non-pharmacologic therapies, superficial thrombophlebitis and an adjacent to anticoagulant with DVT. Bed rest, usually recommended for 5 days, prevents muscle contraction with walking, which may dislodge clot. Elevation of affected extremity at least 10 to 20 degrees above the level of heart to enhance venous return and decrease swelling. Pillows should be used to support the popliteal space. If the upper extremity is affected, a sling or stocking tape attached to an IV pole may be used. Compression promotes venous return and reduces swelling. Electrically or pneumatically controlled stockings, boots or sleeve. Elastic stockings, garments. Dry heat. Warm water bottles, ultrasound. Acoustic vibration of frequencies beyond human ear perceptions. Moist heat. Hydrotherapy, real pool bath, warm compresses. Surgery, placement of a filter into inferior vena cava to prevent pulmonary embolism in a patient who cannot tolerate prolonged anticoagulant therapy. Thrombectomy may be necessary for severely compromised venous drainage of the extremity. Complications, pulmonary embolism and post-phlebitic syndrome. Caution, avoid massaging or rubbing cuff because of the danger of breaking up a clot which can be circulate as an embolus. Elastic hose have no role in the management of acute phase of DVT but are valued once ambulation has begun. Their use will minimize or delay the development of the post-phlebitic syndrome. Thank you.